Moving ahead, regarding the effects of radiation on the tissues, they depend on the dose and time of exposure and can be in the form of gene mutation, abnormal cell mitosis, and derangement of reproductive ability of the cell, also called as progeria. Another aspect to be considered as far as the radiotherapy is concerned is that the tissue tolerance is variable and is an important factor in deciding the type of the radiotherapy. In this, the various organs of the body are divided into serial organs. That means the functional units are arranged in serially. For example, spinal cord. And parallel organs, that means the functional units are arranged in the parallel alignment. For example, kidneys. The adverse effects in the serial organs is much more as compared to that of the parallel organs. Another aspect is a cell culture technique, which is helps to study the cancer cell kinetics. That you must have already dealt in the chemotherapy of gynecological conditions. So in this one, the pre-mitotic, that is G1, and mitotic phases, that is M, are supposed to be more sensitive to radiation injury. So that's why if we can keep the tumor cells in the sensitive phase and then irradiated, then the maximum tumor cell death can be achieved. If there is a big tumor, then in the center of the tumor, whatever cells are there, they get less oxygen. That's why they will be hypoxic or anoxic cells, and these cells are resistant to radiation injury. That's why means they are radio resistant. So to make that to make them radio sensitive, there has to be more supply of oxygen, and this can be made in the form of hyperbaric oxygen, which is of almost 3 atmospheric pressure as compared to the normal, and this increases the radiosensitivity of normal as well as the tumor tissue. However, hyperbaric oxygen has practically has not been that helpful in this context. So there are certain chemicals which make this tumor more sensitive to radiotherapy. The details will be dealing later. And hypothermia is also found to increase the sensitivity of the tumor. Now coming to the radiation therapy per se, the goal of radiation therapy is that the maximize tumor cell death while minimizing the damage to healthy cells. This has been the concept for last so many years. There is never any reason to give any dose to uninvolved normal tissue, but practically it is not possible. An increase in the dose to the tumor will to a point improve local control of that tumor, and achieving these objectives is self-evidently true and does not require randomized prospective trial. It's very clear on its own. So what are the various techniques of radiotherapy? The mains are the brachytherapy and external beam radiotherapy. And brachytherapy is an integral part of the radiotherapy in gynecological cancer. It's a form of radiation therapy in which the source is placed close to the tumor and it gives a very high dose of radiation. The application in this case may be in the form of needles implanted into the tumor or placed in the cavity of that organ. The second form of technique is external beam radiotherapy, ERBT, or also called as teletherapy. In here, treatment with beams of ionizing radiation are produced from a source external to the patient. In brachytherapy, it is internally placed, whereas in the ERBT, the source is external to the patient. And then there is a radioactive solution, which is given in the form of isotopes. For example, the solution is put in the peritoneal cavity. Mostly it is used in the secondaries in the various cavities. So coming to the brachytherapy, this can be given in the form of intracavitary, interstitial or internal method. In the intracavitary, this is the mostly used. It plays an important role in the treatment plan and can be given in the like a low dose rate or in a high dose rate. So then there is some certain pre-radiation preparations in brachytherapy required, like for example checking of the hemoglobin, then the WBC and the routine examinations, routine lab investigations. Then the rectal enema is to be given or suppository, and antibiotic cover is to be given before instituting brachytherapy. So these are the picture of various brachytherapy machines which are utilized for administration of brachytherapy. So intracavitary therapy, brachytherapy, which is most commonly used. Once the central disease has shown good response, the brachytherapy is delivered either by interdigitating with the external radiotherapy or at the end of external radiotherapy. So it plays an important role in the treatment plan. Here usually the main emphasis is on the mainly used in the cervical cancer, and then main emphasis on the radiation, that the maximum dose of radiation is in the near the cervix or the surrounding area, and the dose decreases. There is a rapid fall off of the dose as it goes to the paracervical tissue and the parametrium. The resultant radiation zone obtained with this intracavitary brachytherapy is like a pear-shaped, which is evident over here. So this intracavitary brachytherapy is performed under general or local anesthesia or under heavy sedation. A self-retaining urinary catheter with 7 ml of radio contrast in the balloon is inserted into the bladder. For routine gynecological application, standard applicator include an intrauterine applicator called the tandem, or this one, and a pair of vaginal applicators which are called as ovoids, or also called as colpostats. So before introduction of these tandems, the cervix is dilated to allow the insertion into the uterine tube. The tandems are available in different curvatures to be adapted to different uterine shapes and can be adjusted to different uterine lengths also. And ovoids are also available in the different sizes, are inserted into the vagina. The radioactive sources are loaded into the applicators by a remote computer control unit called as an afterloading technique. And radiation can be delivered at low dose or at high dose dose rates. So whenever you are doing intracavitary application, it shows a isodose distribution as shown in the figures earlier. So after the introduction of those tandems and the ovoids, there's a radio-opaque vaginal gauze is applied to secure the devices in place and fix their position related to the bladder and rectum. And this gauze is packed in such a manner that the bladder and rectum are displaced away from the radiation source. So contrast material in a Foley catheter and a rectal tube can be used to identify the International Commission for Radiological Units, that is ICRU, reference points of interest. Will be coming into the subsequent slides. So this is showing the diagram of the uterus. Here with the intracavitary or the tandem, this is the applicator, and these are the two ovoids placed in the vaginal fornix. And mostly this is used in the radiotherapy of cancer of cervix. So there are two prescription points are usually used to define the dose delivered. Point A, which will be shown in the next slide, is 2 centimeters lateral to the uterine axis and superior to the external os, and point B is 5 centimeters from the midline. So point A corresponds to the area where the uterine artery crosses the ureter, and point B corresponds to the pelvic side wall, and the location is of that of the obturator lymph nodes. So here we can see this is the intracavitary or the tandem and the ovoids over here. This is the point A, which is 2 centimeters away from the midline and 2 centimeters above the external os, and point B is 5 centimeters from the midline and at the level of the point A. So this is point A 2 centimeters from the midline, and point B is 5 centimeters from midline. This is the sagittal section of the same. Let's show the balloon with a contrast material, and the rectal reference points are also there. So intrauterine, these tandems have been placed, and the intravaginal source is also there. So we will not be going into the details of it, which is very complicated. So the summated dose, that is the dose of the teletherapy and the brachytherapy to point A, is adequate for local control and is estimated to be between 75 and 80 gray for early stage and 85 to 90 gray, both low dose rate equivalent doses, for late stage disease respectively. So as the dose increases, it is necessary to reduce the total dose delivered by the brachytherapy and fractionate, that's usually 1 fraction per week, to avoid normal tissue complications. So the dose received at point B is usually 1/3 of the dose at point A. So low dose rate doses range from 25 to 30 gray to point A, and high dose rates doses range from 18 gray in 2 fractions to 24 gray in 4 fractions. And radiation can also be delivered as an interstitial implant if the anatomy does not allow for placement of the intracavitary applicators. So various isotopes are used in case of brachytherapy depending on their half-life. The lesser the half-life, the least half-life that can be kept, those isotopes can be kept inside permanently, and little higher half-life than those applicators are kept temporarily over there and removed after a prescribed dose. Once the prescribed dose is received. So interstitial brachytherapy, as we have seen, if the cavity is not satisfactory for intracavitary brachytherapy, then this method is utilized. This involves implanting radioactive seeds into or near a cancer tumor, and the seeds may be left in place temporarily or permanently. So now coming to the external beam radiotherapy, or ERBT. In here, the delivery of radiation where there is a radiation source external to the patient, and superficial tumors are treated by superficial X-rays or electrons, and deep-seated tumors are treated by megavoltage X-rays delivered by linear accelerators or gamma rays, which is generated by cobalt-60 units. Before giving the external beam radiotherapy, a radiation oncologist has to plan how the radiation is to be given, what is the dose, and at what areas to be given. So that is known as radiation treatment planning. In that, first it is planned where is the target tissue, where the normal tissue, and then the cross-sectional imaging by CT or MRI is done. So directly it utilized to delineate the tumor and the normal tissue, which can be done by various methods, which will be coming subsequently. Thus the tumor and the normal tissue can be more accurately defined, and the dose is calculated. So dose calculation can be more precise if the structures are delineated properly, and more options are available for plan optimization. So radiation treatment planning. There are various methods of radiation treatment planning which the radiation oncologist can utilize. The conventional planning, which was used earlier, determines the exact location of the tumor. Then the cross-section of the body contour in the tumor plane is drawn, and the location of tumor is marked. Here it is showing the conventional planning, and here the delineation of the tumor is done. And then there is a 3D CT planning, uses a CT scan based simulator where the patient's tumor region and the surrounding risks are delineated, and the 3D volume is rendered. This is much better than the conventional planning. And going further, it is intensity, and here it is 3D scan CT which has been shown. And going further in technology, it's an intensity modulated radiation therapy planning is also there. It's a more technologically advanced, and the target dose and the dose constraints are predefined in the planning software, and to a complex algorithm by the intensity modulation, the dose is sculpted around the target while respecting the dose constraints of the surrounding organs at risk. So, as we've seen, external beam radiotherapy can involve simple two-dimensional radiotherapy, which was being used earlier. And the more advanced is the 3D conformal radiotherapy, where the angles are conformed to what is required according to the 3D mapping. And then the immobilization devices are used, and various simulators which can be used as 2D stimulators, then the CT stimulators, MRI, and the PET-CT simulators. So this is the diagram of the linear accelerator in this one, and here the linear accelerator, the radiation is being given. External beam radiotherapy is being given to the patient. The radiation beam and the radiation field has been delineated. So in this way, this linear accelerator can target and destroy cancer cell in a precise area of a patient's body with minimal exposure to the surrounding healthy tissue. This is the external beam radiotherapy being planned. First planning is done, and later on the radiotherapy will be given to this patient. So, like we had discussed earlier, after the 3D CT mapping, the further advancement is the intensity modulated radiotherapy. It's a novel approach to the planning and delivery of radiotherapy. Unlike conventional radiotherapy, IMRT conforms the close dose to the shape of the target tissue in 3 dimensions, sparing the normal tissue as far as possible. So here there is a normal tissue sparing, so that's why decreased toxicity and hence increased patient quality of life. There's increased ability to escalate the dose, and then the increased tumor control is there. So VMAT is another volumetric arc therapy, is a form of intensity modulated radiotherapy. And this radiotherapy machine rotates around the patient during the radiotherapy session in an arc shape. So pelvic radiotherapy was being given earlier. Here treatment of large volumes of the rectum and small bowel also come in the way, and that's why this exposes the patient to gastrointestinal toxicity. So this is overcome by IMRT. So this reduces the dose to the small bowel and the rectum. So during IMRT planning, the target dose and the dose constraints are predefined in the planning software. So this is the intensity modulated radiotherapy, and here this is VMAT also. It rotates around the patient in an arc-shaped fashion. So is IMRT that useful? So there have been some important concerns against IMRT. One is that while the IMRT reduces the volume of the normal tissue receiving high doses, however, it increases the volume of normal tissue receiving low doses. So this concept raises concern about the potential induction of second cancer. However, in over a decade of use, there has not been increased rate observed of the secondary cancers, but all these patients need to be carefully followed up. So what are the limitations of IMRT? There's a significantly increased expenditure. One is a machine with the treatment capability, that is the imaging equipment, the planning and verification, and the software and computer hardware all entail a lot of expenditure. Then there is the extensive physics involved. That's when the manpower has to be trained for using this IMRT, and time required is much more because of various calculations involved. Then another limitation is the conformal nature. That means the angle between this thing have to be constant, and that's why this is highly susceptible to motion. And then there is frequent setup related errors occur in this. And target delineation remains problematic. There can be interpersonal, intrapersonal, and interspecialist variation in planning the target volume and delineation. And the treatment and planning time both are significantly increased in this case. And what is the radiobiological disadvantage? Though there is a decreased dose rate to the tumor, there is an increased integral dose is there. So another advancement of radiotherapy, external radiotherapy, is image-guided radiotherapy. Is the use of real-time imaging to guide radiotherapy, imaging the patient on the treatment table in the treatment position is done in the real time, and it can be used to improve setup accuracy of patients, manage internal organ motion, and adapt treatment to changes in patient anatomy and or tumor response. So indications of IMRT and IGRT as far as the cancer cervix is concerned is if there is a nodal involvement in the pelvic or then it maximizes the boost dose, and if there is a para-aortic node treatment is done by IMRT or IGRT, then the boost side wall in region inaccessible to brachytherapy, and if there is a recurrence in the radiated area or re-irradiation it is done, and not to be used for routine treatment, and however it is not a replacement for brachytherapy, it's a complementary to brachytherapy. So major issues as far as the IMRT and IGRT are involved is a need for continual replanning given rapid regression of the tumor. Then there's a high margin for error with tight margins, and then there's the increase in the internal dose, and there is a longer treatment times.